Okay, good afternoon, everybody. Thank you very much for inviting me. I'm very glad to share in such a very nice event. Today, we are going to discuss a very important issue, which is how to approach a patient with sepsis and with end-stage liver disease. So first of all, we would like to know the amplitude of the problem. We need to know that among hospitalized patients with cirrhosis, approximately 1/3 develop sepsis and 6% develop septic shock. And studies have shown that mortality among cirrhotic patients with sepsis in the ICU ranges from 18 to 66%, which is quite a high percent. Although a number of landmark clinical trials have paved the way for incremental improvements in the diagnosis and management of septic shock in the general population, patients with cirrhosis have largely been excluded from these studies, and critical knowledge gaps continue to impact the care of such population. This is a table that shows the most recent clinical trials. If you can notice, some trials with a lot of patients, like 1,260 patients with septic shock, and only the involved from the liver disease is 22%, 22 patients, with this around 1.8%. Also, we have this large study, SMART study, is 15,000 patients, and the only included from the liver disease patient is 11%. And over and above, some studies have already excluded patients with liver cirrhosis, so we definitely have a problem. While patients with compensated cirrhosis may do very well with the traditional interventions of septic shock or management of septic shock, patients with decompensated cirrhosis have a marked local and systemic hemodynamic aberrations that make the management and prognosis worse. In cirrhosis, we all know that we have an associated immune dysfunction, and this is dependent on the stage and severity of decompensation. This is called cirrhosis-associated immune dysfunction, and this definitely affects the immune system in both the innate immunity and the acquired immunity. Sepsis by itself is a state of profound immune dysregulation, in which in the initial phase, we have a pro-inflammatory state, and then we have, when we progress into sepsis, there is induced immunosuppression and a stage of immune paralysis with subsequent organ failure development. This is a summary of the pathophysiologic changes in cirrhosis that impacts the management of septic shock. In brief, there is decreased lactate clearance, so we have increased level of lactate. There is peripheral vasodilation, so there is a shock. There is susceptibility to infection, and this is due to a lot of factors, decreased immunity and bacterial translocation. And also, if we are dealing with an end-stage liver disease, so he has got multiple hospitalizations, so the risk of MDR organism is high. Also, the patient has cardiovascular dysfunction. The patient has hypoalbuminemia. This hypoalbuminemia will affect the management of the patient and also the pharmacokinetics and pharmacodynamics of the drugs or antibiotics or antimicrobials we are giving. Also, there is relative adrenal dysfunction. A lot of scoring systems have been suggested for cirrhotic patients with sepsis. So to improve on the prediction of SOFA score in patients with cirrhosis, developing acute decompensation. I mean, if we have a patient with cirrhosis, we will not use the conventional SOFA score. The European Association for Liver Study of Chronic Liver Failure Consortium, the EASL, changed the SOFA score to the so-called CLIF SOFA score. This is the SOFA score, and the modifications that were done for the patient with end-stage liver disease. The platelet count was replaced by the INR, International Normalized Ratio, and the Glasgow Coma Scale was modified to the hepatic encephalopathy as the central nervous system criterion, and this is the CLIF SOFA score. As we can notice, the platelet count was we have, instead of it, the INR, and instead of the Glasgow Coma Scale, we have a grading system for hepatic encephalopathy. So how to diagnose infection in liver cirrhosis? A multitude of biomarkers has been identified. but the CRP, the C-reactive protein, procalcitonin, and interleukin-6 have been the most extensively studied and clinically used. This is a diagram that shows the procalcitonin, and as we know, the procalcitonin, we are not depending on a single measurement. It is better to get serial measurements, and it is good to diagnose bacterial infection and also for early de-escalation of antimicrobials. Also, we have the interleukin-6. According to studies, interleukin-6, if it's above 5, then the risk of death within 12 months is 0. If it's above 37, the risk of death is much higher. Also, we have got a neutrophilic CD64 and monocyte distribution with a neutrophil deformability. Some studies discussed the inflammatory markers on which we can depend to diagnose bacterial infection in patients with decompensated cirrhosis. This study was done in Egypt, and it included about 213 patients with decompensated cirrhosis. Their conclusion was that the presepsin has comparable diagnostic performances to the CRP and procalcitonin, and adding that presepsin to CRP yields the same diagnostic performance as combined CRP and procalcitonin. So if we do presepsin with CRP, it's the same, it's comparable with CRP with procalcitonin. Another study from Romania, and this was conducted on 365 cirrhotic patients. Infection was diagnosed in 134, and they were suggesting that presepsin may be an adequate non-invasive tool for early diagnosis of infection in patients with liver cirrhosis. A rapid diagnostic technique, as Professor Riem he discussed with us, it will be very helpful by molecular methods such as PCR. These were shown to be efficient and effective in isolating the cause of sepsis and also to optimize the treatment of sepsis. Another important point which Professor Riem pointed, patients with cirrhosis have function defect in neutrophil function, so the likelihood of fungal infection is high, so we need to suspect Candida and Aspergillus, and in general, fungal infection should be strongly considered in any patient presenting with abdominal sepsis. So how to manage septic shock in liver cirrhosis? I did not want to go into details. It's the interventional therapy for any septic shock, fluid resuscitation, vasopressors, albumin, antibiotics, low-dose corticosteroids. But we need to stress once more that early antibiotic administration provides the greatest survival benefits in septic shock, as every hour of delay leads to a 7% increase in mortality. We need to initiate antimicrobials very rapidly, but we need also to concentrate on the adequate coverage and the pharmacokinetics of the drug, especially in cirrhosis. So what are the important facts to consider while prescribing antibiotics in a cirrhotic patient? We need to put in mind the altered pharmacokinetics and pharmacodynamics. So Prof. Riem also, he mentioned this, that for highly protein-bound antibiotics like ceftriaxone, aztreonam, or carbapenem, if we have severe hypoalbuminemia, so the unbound portion of the drug will be very high, and the active portion will be very low. And so we will have a lower drug level below the minimal inhibitory concentration, so the drug will be ineffective, so we need to increase the dose. Also, among carbapenem, ertapenem is associated with a 5-fold increase in mortality, which is not observed with lower protein-bound carbapenems, such as meropenem or imipenem. Also, if the patient has ascites, he has an increased volume of distribution. So this leads to a decreased peak concentration. The concentration of the antibiotics will be low, especially the antibiotics that will distribute extracellularly. In case of spontaneous bacterial peritonitis, which is a common source of sepsis among hospitalized patients with cirrhosis, peritoneal antibiotic penetration is an essential concept, because some agents will be very good, like for bloodstream infection, but in a patient with ascites and sepsis, we need to know whether this drug has good penetration to the acidic fluid or not. So cephalosporin and fluoroquinolones and meropenem achieve a high concentration in acidic fluid, while others like aminoglycosides, ticacycline have reduced penetration. In a secondary analysis of the bichrome study, this was discussing about the extended infusion for the carbapenems. We know in the general population, in sick patient, extended infusion is much more preferred than the IV bolus. And also the author found that extended infusion were associated with improved mortality and higher rates also in patients with liver cirrhosis and septic shock. So my take-home messages today: sepsis in cirrhotic patient is a complex and challenging clinical scenario. Early diagnosis of infection in cirrhosis patient is important to improve prognosis. Early management with antibiotics, fluids, vasopressors, and low-dose corticosteroids might reduce the mortality associated with sepsis in cirrhotic patients. Thank you.
Thank you, Dr. Riem. Any questions? Okay, I have a question myself. Which antibiotics would you totally avoid in cirrhotic patients? Or is there no common list that you would?
As our professor mentioned, when we are treating MDR Acinetobacter, sometimes we are using ampicillin sulbactam unacin in high doses, 9 grams, Q8 hours. This is quite a high dose, and sometimes it can lead to a hepatic toxicity.
Thank you. Any questions? Thanks, Dr. Riem.